Hello, everyone. Welcome to your blood pressure, blood physiology lecture. And let's get started. Let's review details from the last lecture, which was basically blood vessel structure. Describe the roles of the following in circulation. Give you a second to think about that. Well, what you should have been thinking about is that the arterial system is a distributing system. They take blood away from the heart, whether it be to the lungs or to the whole body. When we use the term microcirculation, it refers to the smallest blood vessels, which you should know as arterioles to capillaries to venules. Microcirculation. Those blood vessels are so small you can't see them, and so they haven't been named. So when we get to the anatomy of the blood vessels, we're only naming the ones we can see with the naked eye. The venous system is a collection and return system. Okay, the smallest venules and um, small veins, they're kind of like your capacitance vessels, but when they funnel together into the larger vena cava, their job is the venous return. All right, so moving on to the physiology of blood pressure, understand that it's simply referring to enclosed blood exerting a force or pressure on the vessel wall. Okay, so if you look at a cross section of any blood vessel, there's blood inside of there, and it's pushing on the wall, exerting a pressure. And that pressure is what keeping blood to flow. And know that there are actually three kinds of pressures we can use to describe this picture here. It's kind of a free body diagram of a blood vessel in the leg at some kind of given angle, and they kind of draw it out there. And the thing to understand about when you talk about blood pressure, you're talking about a pressure gradient. Blood pressure is always a pressure gradient. Because as you learn from studying the cardiac cycle, blood flows from an area of higher pressure to lower pressure. High to lower pressure, blood flows from high to low. So when we when you measure blood pressure using the pressure cuff at the arm, it's the brachial artery, and well, you're measuring the high point here. And if it's normal, what you say is, oh, okay, well, there's enough pressure so that blood will flow to the capillaries to supply oxygen to tissues. Well, to get to this picture here, the three kinds of pressure are hydrostatic pressure. I won't get too much into this. I'll just say that because we're bipedal and we walk upright, imagine a big tube filled with liquid from head to toe. That kind of represents your vasculature. And there's a force of gravity pushing down. And so this is kind of like the pressure against gravity. I'll say due to gravity. And so on this figure here, kind of zoomed in on this next figure, it's delta H. Okay, the tube is at an angle, but still in the vertical plane, the delta H, delta means change, by the way, when I say delta. The Greek symbol delta means change in science. Delta H, H1, H2, that difference there, you have to account for that. For example, to give you one physiological example, like when you're sitting up, standing up or sitting up, the heart has to pump blood up to your head. For example, when fighter pilots exert their bodies to G forces, and they tip the nose of the plane down and they're flying down, the force down is so great that the heart has trouble pushing blood up to the head. And so sometimes they black out, and there's flight suits and exercises that they put fighter pilots to do to prevent them from blacking out. We'll talk more about that in respiratory, but just to give you an example that this is the thing that sometimes you consider. Um, one more example that we'll talk about later today. For example, when you're lying horizontal, things kind of even out in terms of your uh, blood distribution. But when you stand up, blood tends to pool for 10 to 20 to 30 seconds. And then there's autonomic mechanisms to help re-regulate the distribution of blood because that force of gravity, when you go from horizontal to upright, it changes. And so anyways, for now, hydrostatic pressure, the pressure due to gravity, okay? The next one I'll define is the transmural pressure. Transmural pressure is the pressure difference across the vessel wall. So in this figure here, it's the delta R, R1, R2. And this pressure is important because this is the pressure that your body can detect. Your body can detect transmural pressure. And by the way, like mural means something like you hang on a wall. So transmural means across the wall. Your body can detect transmural pressure because nerve endings live inside there. They're called baroreceptors. Nerve endings, baroreceptors. Baro means pressure, like a barometer, which measures atmospheric pressure. Baroreceptors measure blood pressure. Live inside vessel wall. Now, not everywhere. You don't have baroreceptors everywhere. In fact, there's only two locations I want you to know about, and they're locations in the arteries very close to the heart. One baroreceptor is in the aortic arch. The other is the carotid sinus right here. So baroreceptors live inside the vessel wall at the carotid sinus and aortic arch, close to the heart. And that's important. When your blood pressure changes, you want it to like be close to the heart. And I think I have a picture of that. And those are baroreceptors. And the last pressure I'd like to define is what they just simply call the driving pressure. This is the important one. Let me put it up here. On the figure, it's the delta P. This is the pressure that causes blood to flow in the blood vessel. Sorry, let's look at this again. I'm sorry, it's not delta P, it's delta X. Let me change my note here. So this driving pressure is the difference between a high point and a low point down the central axis of a given blood vessel. The pressure gradient down the central axis of a given vessel. Here's my given vessel. I'm going to draw mine in the horizontal plane, and it's that central axis right down there from high to low, okay? That's what I say here. Flow is dependent upon a pressure gradient, not absolute pressure. So flow, it depends on the gradient between high and low, okay? I'll put that as a side note here. Flow depends on the gradient of pressure, not absolute value. So what I mean by that can be described by just answering this question. Which blood vessel will have a greater flow rate? And you compare two vessels, and you assume everything's equal except for the gradient. The difference between 90 and 10, or the difference between 125. And the answer is, well, flow would be greater in A, because there's a steeper gradient. The difference between 90 and 10 is 80. The difference between 175 is 25. So even though the absolute pressure is higher, 100, the gradient at the other end isn't as much, so flow wouldn't be as much. And if you took a physics class, you could calculate how much exactly. We won't do that. But fluid flow in a physics class, you study Poiseuille's equation, and we won't get into that too much here. But this is the concept you got to understand right there. Flow depends on a pressure gradient, not really the absolute value of the pressure. So now that we've kind of defined the parameters of what blood pressure is, let's kind of apply it to the circulatory system and talk about how the body maintains it. So when I say MAP, MAP stands for mean arterial pressure. Mean arterial pressure. And so, how is it maintained? You must control the inflow and outflow of blood in systemic arteries. Okay, so let's remember our blood vessels: systemic arteries, systemic veins, pulmonary arteries, pulmonary veins. In medicine, they strongly monitor systemic arteries. That is the blood pressure that really keeps you alive, because that is the blood that is flowing to your vital organs, heart and lungs, brain. So you must control inflow as well as the outflow, okay, of blood into systemic arteries, okay. So control blood flow systemic arteries. Now here's a simple diagram of the circulatory system: heart, arteries, capillaries, veins. Okay. And so to remind you of things that we talked about with arteries, for large arteries, the capacitance is small and the capacity is fixed. If you look at your notes, I describe them as a stiff vessel with a small capacitance. They don't hold very much, maybe 15% of blood at any given time, blood is flowing. Therefore, arterial pressure is controlled mostly by controlling the inflow and the outflow of blood. Blood comes in, blood goes out, and you control that. You control the pressure of the fluid inside the arterial side. Not even talking about this side yet. So just to understand this simple figure, let's review CVP. Okay. Well, I don't want to go too fast. Just to go back here, outflow is controlled by the peripheral resistance provided by arterioles. Arterioles, remember, those are your feeders to the capillary beds. Once blood leaves the arterioles, it's into the capillaries. It's out of the arterial system. Arterioles, for that reason, are sometimes called resistance vessels. So the peripheral resistance, that term, peripheral resistance, is anatomically controlled by arterioles, your resistance vessels. Okay. So what is resistance? Resistance is resistance of blood flowing. So you always want to keep some tone on those arterioles. If they just open wide open, all the blood will leave the arteries and pool in the veins because the veins can take it. And then you'll die because all the blood will be here and none of it will be circulating here, pumping blood to your vital organs. Okay. That's why you always need some tone on here to keep it from flowing out too much, to keep pressure inside here at a normal value, 120/80. You must control the outflow by always having some sympathetic tone to have a normal amount of resistance to keep blood pressure up. That's the outflow. The inflow is simply provided by your cardiac output, which you already know about. Cardiac output is a product of heart rate times stroke volume, and we learned about that in the previous chapter. So the inflow and the outflow. Let's review the concept of CVP. C is capacitance, V is volume, P is pressure. We talked about arteries as their small capacitance, right? That's how I define the concept. Even though we're using a mathematical equation, we won't plug and chug numbers. We'll just talk about it conceptually. Arteries are small capacitance. They don't hold very much blood. The blood they hold, well, let me define it this way. I said that arteries are small capacitance. That C, that number, it's a small number. What I had said was arteries hold a small volume of blood, okay? So imagine a small number in the numerator, but the pressures we observe are very high, okay? So if you divide a small number by a large number, you get a small number, okay? Arteries are small capacitance. Veins are a very compliant vessel. They're very large capacitance. In fact, they're called your capacitance vessels or blood reservoir. And we said that we observed low, I'm sorry, I got to clear my throat. All right, I think that's better. Veins are large capacitance, big number C. They hold large volumes, large number, but we observe low pressures in veins. When you divide a large number by a small number, you get a large number. So that's the relationship. That's what CBP is. Okay, moving on. So blood flow is determined by cardiac output. That's what is really causing the blood to flow. So that's why we study the heart first. And you already know that flow, F, and cardiac output is CO. So we basically, in my mind's eye, in a physics class, you just talk about flow of any fluid with capital F. But in this class, since the blood flow is determined by cardiac output, I'm just going to use cardiac output as our blood flow. And we know the determinants of cardiac output are heart rate multiplied by the stroke volume. So that's our inflow. Okay, and that determines our blood flow. To be really strict, flow of any fluid flow of a fluid is flow past a fixed point. So if cardiac output is our reference point, our fixed point is the aortic semilunar valve. Okay, that's flow. That's our inflow. Our outflow is peripheral resistance, or just resistance. You can call it a peripheral resistance or just resistance. Sometimes I just usually call it a capital R or PR if it's peripheral resistance. And it's just resistance, anything that provides resistance from blood flowing. The main thing that provides resistance from blood flowing is friction against the vessel wall. So resistance to blood flowing mainly provided by friction against the vessel wall, because blood flows in vessels, as you well know. And the thing that determines friction against the vessel wall is the radius, the diameter of the vessel, which is largely dependent on the vessel radius. So vessel radius, imagine a circle, geometry class, point in the center, distance from the center to the edge, radius, good old-fashioned radius. So here are all the determinants of resistance to blood flow, anything that opposes blood flow. 4 determinants I usually address are blood viscosity. Viscosity is the goopiness of blood, provided mostly by the hematocrit, the red blood cells. If hematocrit is higher, blood is more viscous. For example, maple syrup is more viscous than water. So we want to keep it relatively, well, let's put it this way. If blood gets too goopy, too viscous, it may impede blood flow. And when that happens, you give a chance for the intrinsic clotting factors in blood to accumulate in blood that's not flowing well. You can get spontaneous clots, and that could be a problem. So anyways, it's pretty much constant in an adult with no pathology of the blood. Um, so I really don't talk about it in this class. It just remains constant in adults. Blood vessel length. Okay, well, for viscosity is the idea is if you increase viscosity, V, you increase resistance to blood flowing. But it's pretty constant, so I don't talk about it. But it's the same thing with vessel length. It's pretty constant in an adult when you stop growing. If a blood vessel is at a given length, um, basically, if similar blood vessel, all things being equal, is twice as long, this vessel would have an increased length and increased resistance simply because it's longer and there's more friction because it's longer. Okay, so that's the relationship there, but it's constant in adults because you stop growing. The only thing you might consider is if you put on a lot of weight and all that weight needs blood vessels, and so you provide more blood vessels, and maybe then you can consider it. But in absence of dramatic weight gain or loss for that matter, this is constant. I don't really talk about it too much in this class. Another thing is turbulent blood flow. Turbulent, we'll say versus laminar. In a physics class, when you describe laminar flow of a fluid, and the same is true of blood flow, you have these nice straight linear lines of blood flowing in a tube. And the arrows are like vectors. They have, the blood flowing in the center of a tube is the fastest because it's frictionless in the center. But as the layers of blood get closer to the vessel wall, you start to have some friction. So the velocity is slower where it touches the vessel wall, fastest in the middle for laminar flow. Turbulent flow increases resistance. So increase turbulence, increase resistance to blood flow, capital R. For example, if you were to have some kind of plaque in the vessel wall, that little bump in the road, you would have to flow around it, and it would create all these little eddies and swirls. Turbulent blood flow increases resistance. Basically, not good. It's something I really don't consider in this class. Atherosclerotic plaques and other things that may cause turbulent blood flow, but be aware, turbulent versus laminar. Laminar is preferable. You can get turbulence if there's a fork in the road. Okay, like what if I'm running out of room to draw here? What if this forks out? Which would happen when arteries branch. That at that fork in the road, you're going to get turbulent blood flow because you have to like go one way or the other, and it causes a little bit of turbulence. So it's unavoidable. But the idea is increase turbulence, increase resistance to blood flow. That's basically you got to know about that. However, the thing that determines peripheral resistance the most is the vasoconstriction, like I had mentioned before. So what I'll say is that vessel radius, little r, not to be confused with big R, capital R, which is overall resistance, but little r, resistance, um, has the most effect on big R. Okay, so little r has the most effect on big R. In fact, how they write about it in your book is peripheral resistance is inversely proportional to vessel radius. In fact, it affects it to the fourth power. Exclamation point. That means radius affects resistance a lot. Okay, um, and I talk about this one the most because it's the body, it's one that nervous inputs and other things can affect. And so this is the physiology that your body can modulate. So we talk about it a lot in the physiology class. Just to give you a simple example of the effect of little r, big R. So say, for example, you got two equal blood vessels, but the radius is different by 0.8, 5 versus 4.2. If you did the math, which we won't, but I'll just tell you, say flow here is 10 mils per second flow rate. Here, just reduce it by 0.8, flow is reduced by half, 5 mils per second. So by reducing vessel radius by 16%, you decrease flow by half. Once again, underscoring this relationship that resistance is inversely proportional to vessel radius. Vessel radius affects peripheral resistance a lot, to put it in simpler terms. Okay. So let's start to talk about how blood vessels can affect vessel radius. We like to talk about the arterioles and the venules. Consider arterioles versus venules. Their vessel radius. Changing it at that level is what we'll focus on in terms of controlling blood pressure. Arterial pressures, they have controls. Some are intrinsic, some are extrinsic. For intrinsic controls, just think about the stuff in the blood, things that are going to make the arterioles, molecules in the blood that will make the arterioles vasodilate or vasoconstrict. But there are also extrinsic controls. And that's going to be sympathetic inputs. Intrinsic input molecules that cause vasoconstriction, VC, vasodilation, VD. And the sympathetic inputs can do it too. They can make it constrict more, vasodilate more. And so we'll discuss both here. So on this slide, we'll talk about the intrinsic controls, which are, we call them localized or autoregulatory. They kind of self-regulate. And the goal is to prevent ischemia. You can't have blood flowing to all capillary beds all the time. Sometimes you shut it off. But sometimes when the cells need oxygen, you let the blood flow through. On or off, you prevent ischemia. Versus a widespread, so I show the whole system here. A sympathetic response is usually in response to fear or pain. It's the fight or flight response. And it's widespread, it's systematic, it's extrinsic because you have extrinsic nerves innervating the arterioles. And that helps increase blood pressure. So we'll talk about both. The localized and the widespread. We'll talk about localized first. So what molecules alter arteriolar resistance locally? In my little diagram here, I have a small artery branching off to our arteriole, which supplies the capillary bed and the venule, and I've illustrated the precapillary sphincters. There's a rhythmic vasomotion. That means they rhythmically contract and dilate to constrict and dilate the vessel. There's a rhythmic vasomotion with local but not direct neural control. So these happen independent of the sympathetic inputs I'm going to talk about next. Let me erase this. So remember, these cells need O2. So you got to let oxygen in, blood in, so the oxygen can get to the cells that need them. And so you kind of self-regulate. Local metabolic factors always dominate over the sympathetic neural controls and other endothelial-derived vasoactive factors. So let me kind of paraphrase that. So what I'm trying to say is you have intrinsic factors which act locally. You have extrinsic factors which act widespread across a whole system. And that's your sympathetic nervous system, your autonomics, sympathetic response. So what I'm saying here is the local ones are determined by, I said, molecules or metabolic factors. Just stuff in the blood, molecules in the blood, metabolic factors. And I give you a few examples there. Things like potassium, CO2. If these things elevate, or if you get a decrease in O2, or if you get nitric oxide, this is the one endothelial derived factor I want you to know. These don't necessarily come from the endothelium. Endothelial derived factor. So these things, 1, 2, 3, I give you a few things there to know. These all vasodilate. What I'm saying is these all vasodilate to let the blood flow, and they dominate over any sympathetic inputs that may come into play. Okay, sympathetic inputs will vasoconstrict. We call it sympathetic tone, neural input. Like the volume knob. Turn up the volume knob, you get more tone. And when you do that, you vasoconstrict, VC. Increase tone, increase the vasoconstriction of the arteriole. Okay, so that's what the sympathetic nervous system does. Put a line here. What I'm trying to tell you is these local metabolic factors will always dominate over this. Okay, because you have to ensure that you can vasodilate to make sure these cells get the oxygen they need. Okay, so this happens locally, kind of self-regulates. I call it a rhythmic vasomotion. It just kind of does it by itself. And so I've given you a few molecules to know. There's more. You can look it up in your book. Let me give you a page number for that. To refer to, just give me a second here. I hit the pause button. I'll look that up. Figure 1916 in the latest edition of Mariab talks about this. Gives you nice figures to look at. So to summarize the local effect on arteriolar resistance, where you affect the vessel radius, basically here, look right there, you vasoconstrict, you clamp down in one location, you're reducing the radius and you're increasing the resistance for blood to flow. So these may not be getting oxygen at that time. When they need oxygen, you vasodilate. That's why I have the arrows reversed. And this kind of self-regulates, okay? Local capillary beds alternate between vasoconstriction and dilation to prevent ischemia. That's the take-home message there. So I did a zoom in on just the little arterial part. You're just squashing it with those precapillary sphincters, or you're dilating. Restrict blood flow, allow blood to flow. Okay, and it happens because of these metabolic factors, which will cause vasodilation. This one. And when there's plenty of oxygen, you may constrict. When there's not enough oxygen, you dilate. Restrict blood flow, allow blood to flow locally, intrinsically. It auto-regulates. The body just does a good job of that in the absence of any pathology. The extrinsic controls is your sympathetic nervous system. So I'm going to add to my picture a nerve input on those precapillary sphincters. And I ask the question, what alters arteriolar resistance extrinsically? You already have it in your notes here. Let me erase this. So the basic idea here is what you're seeing in that previous slide, where you constrict and dilate. Okay, the same could be said for the extrinsic controls. What would happen is, for the extrinsic controls, for vasodilation, you kind of like turn off, you block that sympathetic input. Okay, turn parasympathetic on, it blocks the sympathetic nerve, causing it to vasodilate. So compare vasodilation to vasoconstriction, talking about sympathetic inputs. Blood vessels do not have a dual input. They don't have sympathetic and parasympathetic inputs. They only have sympathetic inputs. But what you do is you control the sympathetic tone with the parasympathetic. So parasympathetic on, that's a block to the sympathetic. Blocks sympathetic. Okay, so you decrease sympathetic tone that causes VD, vasodilation. But if you turn parasympathetic off, you're removing the sympathetic block. So you increase the sympathetic tone, you increase the vasoconstriction, the VC. That's what I say there. So that's the idea. And one effect will help decrease blood pressure. One effect will help increase blood pressure. So here's a side-by-side comparison going back to my simplified diagram. And I say sympathetic inputs vasoconstrict a large group of arterioles and vasodilate a smaller group. Okay, so here's the idea. Mostly what happens is over here. When you vasoconstrict, sympathetic vasoconstricts, and it does it to a large group, most of your body. It works very well at GI tract and liver. I mean, you're not using your digestive tract during a fight or flight response. So just think of a large group versus a smaller group. So let's say for the large group, I'm going to draw like a bunch of, here's my artery. I'm going to draw a bunch of blood vessels, vasoconstricted. So here's my large group, and my sympathetic nerves are they're clamping down at one point. And this happens very well at GI tract and liver. And that keeps blood in the main artery. So the blood pressure is elevated, and you're shunting that blood to where you need it in a fight or flight response to a smaller group, which is mostly the skeletal muscles. So you vasodilate here, so you constrict here, but then a smaller group, I'll just draw the blood vessel bigger. I'll try to. And this will happen at the skeletal muscle. So you constrict, you dilate. This is the skeletal muscle. So let me kind of draw it, dilate it, so you increase the blood flow to the working muscles that you're using in your fight or flight response. So basically large group, small group, and I want you to know that. Here's the kind of pictures in the book that kind of show you vasodilation and constriction of arterioles. Here's the professional picture of showing you vessel, viscous flow in a cylinder. That if you think of a blood vessel and the blood flowing in the vessel in layers. Think of blood flowing in layers or shells in a given vessel. There's a perfect center, okay? And then the layer, the centermost layer, which is not in contact with the vessel wall, has the fastest velocity of blood flow, okay? Now, layer 0 is the vessel wall itself, but that first layer, layer 1, has the most friction. So this layer out here, this layer 1, so its blood vessel, if you measure the velocity of blood flow, is the slowest because it has the most friction. It rubs against the vessel wall the most. But as you get progressively closer to the center, away from the vessel wall, you have less friction and more velocity. So you get closer and closer and closer. Okay, so that's what the data shows. That's why you get this picture like that. So the vessel radius is key. That is why when you're vasoconstricted, you increase the resistance because you have proportionally more layers in contact with the vessel wall. When you vasodilate, you have more layers not in contact with the vessel wall for less resistance, okay? So little r, when you decrease little r in vasoconstriction, I'll just say VC. I don't have a lot of room on this small board. When you decrease little r in VC, you have proportionally more layers of blood in contact with the vessel wall. Again, I'm running out of room. I'll just say rubbing on wall. Different way of saying the same thing. So that's kind of why. If you kind of change the caliber of this vessel, more shells are in contact with the vessel wall, so you increase the resistance to blood flow. So basically, decrease little r, dramatically increase big R. That's kind of the net effect right there. And generally speaking, when sympathetics vasoconstrict that large group, you see an increase in the patient's blood pressure, in the person's blood pressure. So let's switch from arterials and start to talk about venous pressures. Venous pressures are different because you're very far away from the heart. So blood flowing in veins, the pressure observed is very low. So how do you accomplish venous return without pressure pushing it forward? There's other things you must consider. One is lumens. Two are the fact that veins have valves, and there are two venous pumps I'll talk about. So in venous pressures, basically what I'm trying to say is that they're low. So how do you accomplish venous return? How do veins accomplish venous return with very little pressure? That's the question here. Well, consider the fact how big they are. They have large lumens, so there's less resistance to blood flow. Larger than an artery, so you decrease resistance to blood flow. Okay, good. That helps. And the other is venous valves. Arteries don't have valves, veins do. Prevent backwards blood flow. So in a generic example over here, A, if you squeeze the tube filled with fluid, you'd squeeze the fluid in both directions, okay? Or here in C, with the valves in a vertical column in each little section there created by the valves when they're closed, you'd prevent counteracting blood flow. Okay, that's what I say here. But in conjunction with skeletal muscles contracting around your veins, that's why circulation works best when you're upright and active and moving around, you're contracting your muscles. You're squeezing the blood, but instead of squeezing it down, the valve closes here to prevent backwards flow of blood, and you squeeze it up towards the heart. In conjunction with what we call the skeletal muscle pump, because these are your skeletal muscles, not your heart muscle. In conjunction with the skeletal muscle pump, you help venous return. So instead of the heart being the pump, it's the skeletal muscles which are the pump. Here's another slide showing you the skeletal muscle pump with the venous valves. It facilitates venous return against hydrostatic pressures. So in here, when the muscles relax, you allow blood to enter this center chamber here, this part of the blood vessel. And then when the muscle contracts, you close one valve at the bottom, open the top valve to help the venous return. When the muscle relaxes again, you repeat. You close the top valve, open the bottom valve, let more blood in. It's kind of like its own little cardiac cycle, except it's a vein. So this is why the skeletal muscle pump, the venous valves, they kind of work together. The other pump I'll mention is the respiratory pump. In this picture here, the person's lying down. That eliminates the hydrostatic pressure. And what I'll teach when we get to respiratory is every time you breathe, breathe in, breathe out. When you breathe in, your chest cavity expands. You increase the thoracic volume. That decreases um, the pressure inside the chest cavity. So that'll help create this negative pressure in chest veins. So here the atmospheric pressure is 5 millimeters of mercury less than it is here in the extremities. That creates a slight gradient to help return blood to the heart. So it helps to lie in the horizontal position to eliminate hydrostatic pressures. Now, you don't want to lie down you don't want to be sedentary in bed for too long. Circulation is best when you're upright and active, but to treat an acute person maybe suffering heat exhaustion or something like that, just, for a short time, hey, just lay down, relax, help the blood to circulate, take deep breaths, right? Respiratory pump. Create negative pressure in chest veins by breathing in. We breathe by negative pressure. That helps create a gradient for blood to return to the heart, okay? So let's kind of talk about how the sympathetics affect the venules and small veins, because they affect them differently than arterioles. So here's a side by side. So what we had said was the sympathetic inputs for the arterioles, it's like clamping down at one location. So for arterioles, it's like just clamping down one part right there. That really helps decrease little r, increase capital R. Okay. Large group, small group, basically. This is the large group. What it does, it restricts the blood flow to help increase the blood pressure. For veins, it's a little bit different. Here's what I have pictured there. For veins, instead of clamping down at one location, it's like you decrease the radius a little bit over a larger area. Decrease R a little over a larger area. The interesting thing is, when you do it this way, you don't really increase the resistance to blood flow. What you're doing is you're decreasing the size of the whole container. What we say is there's no effect on resistance. You really affect capacitance. So no effect on capital R. You really decrease capital C, capacitance. And that's the key here. There's a difference there. You're in a fight or flight response. And what are you trying to do? You're trying to increase the blood flow in a fight or flight response. And all the blood is sitting in your veins. So you don't want to restrict blood flow in the veins. What you want to do, this is a much better way to do it. I used to be confused on this because I remember I went to office hours and I said, so you said for when you decrease radius, you increase the resistance to blood flow, but you didn't say that for veins. And why is that? And my professor gave me this analogy of the garden hose. Like if you turn on a garden hose and let's say you just squash one part of it, I mean, the water would stop flowing, right? If you just squash down on one part of it or put a kink in the garden hose, right? And the water would stop flowing. And that always happens to my old garden hose. I got to find where the kink is so the water will flow. But what if you took the garden hose, instead of putting a kink in it, you just took the whole garden hose and you shrunk it just a little bit? Well, that would not stop the water flowing. In fact, you'd increase the water flow. And that's the goal here by doing that. Taking the whole garden hose and just shrinking it a little. That would actually increase venous pressures, increase venous return, increase cardiac output, which is what you want in the sympathetic response. So that's the difference. And I have some of that verbiage on the next slide here. We call it the mobilization of the blood reservoir. Mobilization of the blood reservoir. All the blood's in your veins. Your veins are your blood reservoir. So by affecting it this way, you're increasing the blood flow. Sympathetic stimulation to venules and small veins generates a small constriction over a large cross-sectional area. Okay? This picture here. The change in radius affects the capacitance, venules, and small veins with no effect on resistance to blood flow. So a slight decrease in little r, no effect on big R, really. I'll just say no effect on R, not increase R on resistance to blood flow. Rather, you decrease capacitance. Changes in capacitance rather than resistance occur because of the large cross-sectional area influence. So really what you're doing is this effect, the effect is to decrease capacitance, increase venous pressures, which will help increase venous return, and to due to Starling forces more in, more out of the heart, increase cardiac output. And that's the key there. More in, more out. We learned about that before. And that's what you want for a flight or fight response. Here's a picture I like to use showing arteries, capillaries, veins. How you can see how they have a little more inputs here as they do here. Affect a larger cross-sectional area, and you only slightly affect resistance. Here's a summary of how we've maintained blood pressure. So blood pressure is maintained by the things on this side of the equation: cardiac output, heart rate, stroke volume, and peripheral resistance, controlled mostly by the vessel radius. So 1 and 2 maintain blood pressure 3, not the other way around. There's examples that we usually talk about in blood pressure regulation and how it can be altered. For example, the condition of rest versus exercise. Look at the increase in cardiac output from 5,800 mils per minute to over 17,000. And also look how you have a change in the distribution. Most notably, the skeletal muscles, a tenfold increase, and the skin, almost a fourfold increase. And other things are maintained constant, like the brain. The heart increased threefold, and the abdomen, gut is decreased by half, more than half. And so these are good examples in alterations in arterial resistance that change the cardiac output distribution. These things work together to distribute the blood to where you need it to go. Another example in changing the cardiac distribution is hemorrhagic shock. Here, well, basically, you're trying to preserve blood. Okay, so let me write this on the board. So let me this topic is examples in alterations of cardiac distribution. This is called exercise hyperemia. What you want to do is compare versus rest. You kind of see the change in distribution there. A hemorrhagic shock is a little bit different, but shock is a lack of blood flow. And in this figure here, I used to teach hemorrhagic shock. You're seeing on the x-axis the percentage of total blood removed, which is a sterile way of saying you're bleeding to death. Remove blood. And this is the cardiac output and arterial pressure. So hemorrhagic shock is basically lack of blood flow. So what you want to do is monitor arterial pressure. That's the key vital sign to life. Because you want to keep that cardiac distribution, you want to preserve blood flow to the vital organs. So let me kind of explain this figure a little more. Let me take a picture of this. So I'll call this the shock figure. Notice that 20% blood removal. Notice that you can remove 20% of the blood and arterial pressure actually remains constant. Mean arterial pressure is maintained. It's amazing. You've lost a lot of blood, 20%, and you still maintain blood pressure to keep blood flowing to the vital organs, heart, lungs, and brain. This underscores the value of sympathetic reflexes. Which we just talked about. You're really vasoconstricting. VC, vasoconstrict arterioles, right? you vasoconstrict veins, the effect of the arterioles is you increase resistance. That helps reduce the outflow to keep blood in the arteries. The veins, we just went through that whole rigmarole where you don't really affect resistance. What you're doing is you're decreasing the capacitance to increase the venous return, and then increase cardiac output. Okay, that was the effect of the venules in the small veins. And you're really attaining heart rate max about 180 for most adults, BPM. So these are the sympathetic reflexes. Get your heart beating as fast as it can and constrict the arteries and veins in a way to keep blood pressure elevated during this. They call this 0 to 20% blood removal, the first plateau. So I'm trying to write that somewhere. First plateau. Plateau is flat. It kind of stays elevated, which is good. Hopefully, first responders are treating you. Continuing on with this figure, people always, I've always wondered actually, when people say, oh, you've lost a lot of blood, and I've always wondered, well, what's a lot? Well, according to this data, which occurs, this blood loss from here to here occurs over 30 minutes, not very long. And so according to this, your blood pressure really starts to drop after 20% blood loss. So if you lost 20% of blood, that's a lot of blood. So 20% of blood, average blood volume is about 5 or 6 liters. So let's say 5 liters. So 20% of 5 liters is 1 liter. Here's half a liter. So imagine typical water bottle. Imagine 2 of these water bottles filled with blood. Say you're a first responder, you show up to the scene, and what does that look like? What does 2 water bottles spilled on clothes, on the floor? You look there, you kind of see how much blood there is. Maybe you can ballpark it. If it looks like about 2 bottles full of blood, that's a lot of blood because they're about to go into shock. When blood pressure starts to drop at that point, I'm not a first responder, but imagine you lose consciousness. Probably still have a pulse. And then when you get down here at 40% blood loss, there's this little blip right there. We call that the second plateau. This is where you're basically close to death and the brain is becoming ischemic. And at that point, what the brain does, it maxes out the sympathetic reflexes in an effort to save itself. That's what's happening there. And of course, death would ensue shortly after that. You need to maintain blood pressure. And so I want to talk about another example of maintaining blood pressure over the short term, which is a reflex response over the time course of, say, minutes, whereas maybe over long terms, which is more hormonal controls. And basically, a short term control is by sympathetic inputs, an autonomic response, it's neuronal. A long term control is hormonal, which operate by changing blood volume. And so just to review some of the hormones that we talked about, I made this table for you You are responsible for it on this next exam, but because we already covered endocrine and talked about most of these hormones, I'm not going to reteach them all. Simply just review this table if you need be. So maintain BP long term is by hormones. Review table. This table. You do it by increasing blood volume. Over the short term, it's the baroreceptor reflex, in which we'll study those reflexes. It's the autonomic nervous system. But to review this table, notice that your body is very well adapted to respond to decreases in blood pressure to increase the blood pressure. Okay, so review the adrenal medulla. Epi and norepi can increase the cardiac output and peripheral resistance by vasoconstricting and increasing the contractility of the heart pumping to increase the BP. Atrial natriuretic peptide can actually lower BP, it's only one. The posterior pituitary, through the action of ADH acting on the kidneys, can reduce the fluids lost to urine to increase water reabsorption, increase blood volume, increase BP. Erythropoietin can be released. That'll increase the oncotic or osmotic pressure of the blood to counteract that, to keep blood pressure and blood volume up. And review the RAS mechanism. Okay, I put the question mark because if you need to review it, you do it. And that'll ultimately, through the action of angiotensin II, which can vasoconstrict and also act through aldosterone to increase the reabsorption of sodium, water follows, increase blood volume, increase blood pressure. So review all that if you need to. We'll focus on the baroreceptor reflex, which you should pay attention to this equation here. Blood pressure, again, is a function of cardiac output and the peripheral resistance. These factors maintain the blood pressure. Our nervous system can regulate these cardiac output and peripheral resistance to maintain adequate BP. And because it's a reflex response, you may want to review those basic components in your in the nervous system unit. You need a receptor, which in our case is a baroreceptor to detect the change in arterial pressure. You want to balance it homeostatically. You need afferent pathways to send the information to the central nervous system. Those are our cranial nerves 9 and 10. Our control center in the brain is in the medulla. There's a cardiovascular center there I'll define. And then you need to mobilize, the control center needs to mobilize the correct efferent outputs, whether it be sympathetic, parasympathetic, we'll get into that. You need to affect the correct organs, the heart and the blood vessels. So here's kind of like the figure I used to teach from. Take a picture of this. An imbalance can be, well, blood pressure can get too high or blood pressure can get too low, and we'll consider both. Turn the lights on. Essentially what the baroreceptor reflex can do, if blood pressure gets too high, say in the lab, usually what we do is we subject the subject to slight pain. We do the cold pressor test. pressure in physiology always means increased blood pressure. The cold induces pain. A safe way to induce pain is we have students in the lab submerge their hand in ice water for 3 minutes, and actually it's quite painful. And you could try it at home. Of course, there's no lab liability waiver I'm having you sign, but you can kind of YouTube it. Maybe that's safer. I'll show you an example of it. But that painful response causes this imbalance where you increase blood pressure. The reflex will decrease BP to help keep it at a homeostatic level. And the other end of the spectrum is to do the opposite, drop blood pressure. And in the lab, we do the orthostatic hypotension. Which is to say, simply lie down for a few minutes, maybe 5 minutes, and then quickly stand up. This induces a temporary drop in blood pressure, hence hypotension. When you lie horizontally, blood's all even throughout your body in the horizontal plane. When you quickly stand up, the blood pools down, and that blood pooling needs to be corrected. So that drop in blood pressure when the blood pools is a safe way to drop the blood pressure, without bleeding or something like that, right? Yeah. So we stand up and we kind of see how the autonomic nervous system kind of corrects that imbalance there when blood pressure gets too low. The reflex increases the BP. So it's always if the imbalance is too high, you want to lower it. If the reflex is too low, you want to raise it. Keep that in your mind as you go through these examples. What's the imbalance? You always want to do the opposite. And the baroreceptor reflex is a good way to see how the autonomic nervous system helps your body do that. The orthostatic hypotension is like if you ever lie down and quickly get up and you feel a little lightheaded, that's kind of what we're talking about. So let's do the imbalance where blood pressure is too high. You have an increase in blood pressure. That's the imbalance, and due to the cold pressor test. So again, in my notes, I'll put you want to lower BP if the pressor test is making it too high. Okay, arterial pressure rises above the normal range. So what happens? So basically, whoops, going the wrong way here. Okay, let me show you this picture here. A quick video of a person doing the cold pressor test, I guess, since we're not in the lab right now. No sound. Let me hit the pause button. I don't know what's wrong with my audio here. All right, here we go.
One way to measure pain tolerance is with a cold pressor challenge. In this task, you will be directed to immerse your dominant hand up to your wrist into the cold water tank and keep it submerged in the tank, motionless, for as long as you can. until it feels too uncomfortable to continue. You may remove your hand at any point during the task, but please note that once you remove your hand, you will not be able to retry the task. Your goal is to try keeping your hand in the tank, motionless, for as long as you can. One way to...
Okay, let's move on. When I've done this in the lab, we try to have students keep their hands submerged for about 3 minutes, and in the other arm, you monitor BP, and you should see the pain increase the blood pressure. So what's happening inside the body is, number one, there's your imbalance. Blood pressure too high, you want to lower it. So in step 2, what's happening in the baroreceptor? Remember, we have 2 anatomical locations. The aortic arch, the carotid sinus, and it says that on the slide. But these are basically stretch sensitive. They're mechanoreceptors. Stretch sensitive mechanoreceptors. Mechano means some mechanical stimulus. In this case, stretching will trigger it. And so what happens is, for example, in this physiology test it was done on dogs, by the way, these lines represent action potentials. And when you step from 75 to a higher blood pressure, you stretch the nerve ending inside the vessel wall, and you see an increase in the firing rate. So if you increase stretch, you increase AP firing. And so what you'll end up seeing is you have increased action potentials in the medulla. That's the key there. And the opposite is true. If let's say, for example, R increase in BP, and let's recall which type of pressure can be detected by the body: hydrostatic, transmural, or driving. It's the transmural pressure, or P-trans, like I like to call it. So if you increase the P-trans, okay, that's my shorthand for transmural pressure, increase in P-trans. Increase in P-trans, increase the stretch, increase the firing, increase the action potentials there. And of course, the opposite is true. If you decrease P-trans because of a drop in blood pressure, you're going to decrease stretch, decrease the AP firing, action potential firing, decrease APs in medulla. That's kind of what we learned about the function of the baroreceptors. They're responding to the blood in the vessel by responding to the stretch. If there's more stretch, there's more blood. Pressure is too high, you don't want it too high. You want to keep it at a homeostatic level. So fill in the blank. Baroreceptors lie in the vessel wall and they respond to stretch. The afferent pathways are carried by the glossopharyngeal nerve. And if you study this figure, well, let's just kind of put here afferent pathways for this reflex. Let's remember, afferent pathway means the PNS to the CNS, peripheral to central nervous system. And those nerves that carry those pathways from the baroreceptors, aortic arch, sinus, or basically glossopharyngeal nerve, and if you read some notes, the vagus nerve will too. Where's vagus nerve? So cranial nerve 9, 10. Okay. So in the medulla, there's something called the cardiovascular center. So there's a few centers we'll talk about. There's a cardiac center, and there's two subcenters within that. There is the cardio-acceleratory center and the cardio-inhibitory center. They're listed right there. And the third center is the vasomotor center. It'll help control the blood vessels. So those are the subcenters that control heart and blood vessels that we'll talk about. So now that we have our centers defined, we're controlling the heart and blood vessels. We always have to remember what we were doing. Our imbalance was too high, and we want to lower the BP because that painful stimulus is raising our blood pressure too much. So the autonomic system job is to lower it. So how it can help those increased action potentials that when they reach the medulla, it's the central nervous system. It's the job to interpret and mobilize the correct output. So if this is the signal that the medulla receives, too many action potentials coming in, we need to lower the blood pressure. What it'll do is it'll stimulate the cardio inhibitory center. Okay, you want to slow the heart rate down, and you want to shut off. I'll put a big X. You want to inhibit the cardio acceleratory center. And for the vasomotor center, I'll put another X. You want to turn that down. The vasomotor center is a sympathetic response. And so what you want to decrease that sympathetic tone. Okay, so that's kind of what you do. Inhibit, stimulate. That'll give you the correct output to help correct the imbalance. So here's a figure showing you the efferents. And well, here are the sympathetics being inhibited. The efferent here is the vagus nerve to the heart. So for cardio inhibitory, that center will use vagus nerve. So the vagus nerve carried the afferent and the efferent response, cranial nerve 10. Remember, nerves can be mixed. So I want to show you the sympathetic efferents because T to 1 and to T5 are to the heart, but T1 to L2 is the entire sympathetic range there, and that's to all the blood vessels. So I won't list that here because what we're doing here is we're not using the sympathetics, we're kind of inhibiting them. This is sympathetic, cardio-acceleratory, vasomotor, that's sympathetic. We're kind of like, I put X's next to both of them. We're not using those for this response because we want to lower the blood pressure, not raise it, okay? So eventually, here's what we're doing. Picture of this first. So in this step here, the baroreceptor detected the change. It went to the brain, and the brain's mobilizing the correct output here. So you affect the heart by turning on the cardioinhibitory center. The effect is decrease heart rate, decrease contractility. Remember, that's how hard the heart is beating. Ultimately, that will decrease the cardiac output. In terms of arterioles, vasodilate, VD. So that helps decrease the resistance for blood to flow, right? So ultimately, what we've got here, we always want to relate it back to our question, right here, bring it back to homeostasis. Our equation is blood pressure is a function of cardiac output times resistance. Look what we've done here. We reduce that, down arrow. So therefore, BP is reduced during a painful stimulus to restore the homeostatic balance. So let's do the other imbalance. What if blood pressure is too low? And how does the autonomic system raise it? So we induce that in the lab by an exercise called orthostatic hypotension. And this is also a test they do clinically to test autonomic reflexes in patients. So what if the imbalance is decreased BP? BP is too low. Want to increase BP. So in the lab, we do orthostatic hypotension. It says that right there in small print, probably can't see that. But anyway, stimulus is blood pressure is too low. It's below the normal range. We want to raise it. Here's a clinician trying to show that to you, what it would be like if you were to do it in your patient, if you're a nurse or a doctor.
It is important that all staff understand the procedure for measuring lying and standing blood pressure. This is an important part of assessing a patient at risk of falls. In a number of cases where patients fell in our care and suffered harm as a result of a fall, lying and standing blood pressure had not been carried out, possibly contributing to the fall. A fall in blood pressure on standing is common amongst older adults. This is referred to as postural hypertension or sometimes orthostatic hypertension. The drop in blood pressure is often greater when the patient is taking antihypertensive drugs or diuretics, patients have infections and a fever, or when patients are dehydrated. All three of these are added risk factors that can be treated and the risk of falls lessened as a result. Lying and standing blood pressure should be measured on all patients over the age of 65, including all patients admitted with a history of falls, collapse, or dizziness. Lying and standing blood pressure should be measured first thing in the morning, as this is when it is more likely to be present. As a minimum, it should be measured at least twice in the first 2 days of admission. The procedure for measuring lying and standing blood pressure. Ensure the patient has been lying as flat on the bed as they are able for at least 5 minutes. Take the patient's blood pressure while they are lying down. Ask or assist the patient to stand up. Take the patient's blood pressure immediately on standing. Wait for between 1 to 3 minutes, then repeat blood pressure whilst they are still standing. Abandon the procedure immediately if patient feels dizzy or is about to fall. For some patients who are unable to stand due to their mobility, a lying to sitting blood pressure can be formed as an alternative. Again, ask the patient to lie flat on the bed and wait at least 5 minutes. Take the patient's blood pressure while they are lying down. Ask or assist the patient into a sitting position on the edge of the bed. Take the patient's blood pressure immediately on sitting. Then wait for between 1 to 3 minutes and repeat blood pressure whilst they are still sitting. If at any time the patient feels dizzy or feels like they are going to fall, abandon the procedure. Postural hypertension is said to be present if the systolic blood pressure falls by greater than 20 millimeters of mercury on standing, or the diastolic blood pressure falls by greater than 10 millimeters of mercury on standing. In the event of an abnormal result, inform the medical team and ask them to review the patient's medications urgently. Make sure the patient is well hydrated. Ensure the patient has easy access to the call button and advise them not to mobilize without assistance. There may be a requirement to monitor the patient for postural hypertension on a daily basis until this resolves.
All right, so you see the value of taking these blood pressure measurements in the horizontal position, lying down versus standing up, to make sure your elderly patients can be okay. And basically what you see here is when you stand up after lying down for a while, there's a transient drop in blood pressure. And the body compensates. The autonomic reflexes kick in, the baroreceptor reflex. You see a jump in heart rate to correct the blood pressure. So you drop, go back to normal because of this increase in cardiac output there. So that's essentially what's happening. And so if this is our imbalance, we have a drop in blood pressure due to orthostatic hypotension. What's happening in the baroreceptors, they're experiencing a drop in P-trans. So like we said before, decreased stretch, decrease AP firing, decrease APs in the medulla, in the all-important cardiovascular center. So in the CV center, step 3, call it CV center for short, we had cardio acceleratory, let's just say cardio excel. We have cardio inhibitory, we had vasomotor. And always remember our cheat notes. If blood pressure is too low, what do we want to do? We want to increase the BP to correct the hypotension. So we need our sympathetic response to kick in. So what you want to do is you want to turn off parasympathetic. You want to remove that sympathetic block. That's why I said previously. Turn off parasympathetic. Remove sympathetic block. Put that, emphasize that there. So what you want to do is you want to turn that on. You want to increase that sympathetic tone. Turn on vasomotor center. You return off cardio inhibitory center. Not using that. So the efferents we're using, the sympathetic efferents, T1 to L2, using all of them for the vasomotor center because you have blood vessels everywhere. T1 to L2, cardio acceleratory center, sympathetic efferents, T1 to T5. Remember, these are spinal nerves, not vertebra. Okay. And yeah, so those are the efferents. That's what we're doing with the correct response by the central nervous system. So three things are shown here. We are affecting the heart, the arterioles, and the venules with a sympathetic response. And just to remind you what we talked about before, remember we're trying to increase the BP. So how do you affect the heart? You would do that by increasing the heart rate, increasing contractility. That will ultimately increase cardiac output. How do you affect the arterioles? You vasoconstrict. You go from more of a dilated to more of a constricted response. VC, vasoconstrict. You decrease little r, increase big R. That's what you're doing there. For the venules, small veins. I'll just say veins. So for the veins, remember what you do? It's like I drew this before. You guys kind of like decrease a little bit over a large area. You don't really affect the resistance. You decrease capacitance, increase venous return, decrease C, increase venous return, VR, therefore increase cardiac output. Okay, so look at what we've done here and relate it back to your equation. Blood pressure is maintained by a function of cardiac output times peripheral resistance. We've increased cardiac output and increased the resistance to increase blood pressure to correct the orthostatic hypotension. So in summary, this is what we did. The cold pressure test was an imbalance to raise it, so we saw how the reflex lowered it. And orthostatic hypotension caused the stimulus imbalance to be blood pressure be too low. The reflex corrects it to raise BP. Another thing that we can't do in the lab, even if we were meeting in the lab now, is we can't choke each other out. But this has actually been done scientifically on a TV show I was watching. And here are some questions I usually ask in the lab about what you could do for the baroreceptor reflex, as well as this video we're about to watch. So this is a good slide. Make sure you can answer these questions. Click on this link, queue it up here. Let me queue it up. I'll hit the pause button.
We began this test with a simple question. When it comes to choking power, what squeezes harder, man or snake? The 9-foot python we brought in squeezed with 40 pounds of force. Yeah, it's just tightened up. You notice he's around this? Yes, sir. I'm not growing it up. But that's nothing compared to mixed martial arts legend Fedor Emelianenko. He clamped down with 500 pounds of force. So we know what squeezes harder, but what we don't know is how little force it takes to choke a person out. To answer that, we're using a different kind of dummy altogether. I'm about to get choked out by the fattest man on the planet. That's right. Earlier in the show, sports science host John Brinkus sacrificed his entire body going up against NFL All-Pro defender Chris Jenkins. Now John's neck is literally on the line. John's in trouble. John's going to go to sleep. And, it's not a bad thing. I've been choked out many times. I only have a couple twitches from it now. It's not that bad. The things I do for science. We bring John up with sensors to show us what's going on inside his body as he's being choked out.
So this is a pulse oximeter. So what we're trying to do is we're trying to capture your heart rate, which will probably be high, and the oxygen saturation in your blood, which may go down, depending. So we'll see how the results are, but your heart rate will probably go up because you're stressed. and your oxygen will probably go down.
Do I look stressed?
A little bit.
It'll be okay. Don't worry.
Oh my god. I know, I'm extraordinarily freaked out right now.
Our dummy John's all rigged up and ready to go.
Are you ready?
I'm ready. Are you ready? You're up to 136.
Oh my god.
A heart rate of 136 is almost twice as fast as the average resting heart rate, and we're just getting started.
You're sure you're not gonna crush my windpipe? Alright, please do not hurt me.
We're at 141. Okay, John, are you ready? Okay, are you ready? 3, 2, 1.
John's heart rate spikes to 180. He's redlining, experiencing a severe panic attack, and the oxygen going to his brain has decreased by 15%. With that small decrease is enough to put our host out. John's heart rate and respiration leap in a frantic attempt to get blood to the brain. And when that doesn't work, John's brain shuts down. The brain needs 15 milliliters of oxygen a minute. That flow to John's brain has been cut by 15%. And if it's reduced by only another 5%, it could be enough to put him in a coma or even kill him. But Fedor releases his grip on John's throat. And blood is coming back to the brain. John was choked out in 4 seconds, and it takes him 4 seconds to come back.
I'd like to. I don't know, man.
Do you want to do it again?
Oh my god, I really don't want to do that again.
We know Fedor can squeeze with 500 pounds of force, but with John, he didn't need nearly that much. He only used 40 pounds of force. That's the same amount of choking power as the python. Medical experts say it takes as much force to compress the carotid artery as it does to break this sac. That's less than 10 pounds of force. Not only could Fedor choke 12 times harder than a python, he put our host to sleep in a few seconds. And what did he think of our new dummy?
I have nothing but respect for John. Because from having done it you get a different perspective than just watching me do it to someone else.
That's what we call taking one for the team.
Oh my god.
All right, so there are some review questions for the science of the chokeout. I like to watch it with students. Obviously, we can't do that in the lab, but yeah, they did it pretty safely, and it kind of simulates like by choking someone out, you're compressing the carotid artery, hence reducing the transmural pressure, simulating blood loss. But you're just compressing the artery, and the sympathetic response is the same. You saw his max heart rate be achieved. His heart rate was even elevated before the choke out because your autonomic nervous system knows when something's coming. Correct. You're conscious. You live in the world and you know what's going on around you. When a big guy standing next to you is going to choke you, your heart rate starts to elevate. Doesn't wait for you to be choked. Um, and so here are some review questions on the baroreceptor reflex. And I have more practice questions for you. These I'll do with you. For example, if you want to quiz yourself, you can turn the sound down. Number one, as you decrease vessel radius little r, what happens to peripheral resistance big R? You dramatically increase big R. In fact, it's inversely proportional to the fourth power. That's what we said. Number 2, sympathetic response to the arterioles. A, when arterioles vasoconstrict, how does this affect the precapillary sphincters? Do they open or close? They close, increases big R, increases BP. The sympathetic response to venules, small veins, when they vasoconstrict, is it over a large or small area? A large area doesn't affect R at all, but it does reduce capacitance, increasing the pressure, increasing venous return. It's called mobilization of the blood reservoir. You're shifting the blood from the vein side to the artery side. You're increasing the cardiac output in a sympathetic response. Which vessel will have a greater flow rate? A will, because A has a steeper gradient. What about now? Which will have a greater flow rate? Flow is equal for A and B because the gradient is the same, a difference of 25 in both cases. Flow rates will be equal in A and B. That is true because the gradient is 50 in both cases. 50 here, 50 here. That's the gradient. Calculate mean arterial pressure and pulse pressure. So what you do is mean arterial pressure. I gave you that equation. Okay, I'm not going to write it here. It's all in your notes. I'll give it to you verbally. Mean arterial pressure is the diastolic blood pressure plus 1/3 of pulse pressure. And if you go back and look at those calculations, for these values, it's 120/80. So if you calculate it, it'll be about 93 millimeters of mercury mean arterial pressure and 40 millimeters of mercury for pulse pressure. Given the total area of vascular beds, which will have a slower velocity of blood flow. From this figure, what we learn is if you have a higher cross-sectional area, you slow the velocity of blood flow. So the 4000 will have a slower velocity of blood flow. As you would see, say, in capillary beds, that slower velocity helps have time for the exchanges that you want to be made in the capillary beds. Veins have large lumens. Explain how this reduces resistance to blood flow. With a larger lumen, you have more of these layers not in contact with the vessel wall, which provides friction, less resistance as a result. If you increase heart rate, you would, choose all that apply, you would increase cardiac output, increase blood pressure, A and C. If the parasympathetic nervous system causes widespread vasodilation, which would occur, choose all that apply. Decrease peripheral resistance, decrease blood pressure, B and D. If the sympathetic nervous system causes arteriolar vasoconstriction, this causes increased peripheral resistance, increased BP, A and C. Okay, the sympathetic nervous system in venules and small veins, increased venous return, increased cardiac output, increased BP, A, C, E. Lecture over. Hope you enjoyed it.